everyone. Today, we are welcoming you to another session or another episode of the Vitreoretinal Surgery Around the World. In these episodes, we are hosting a guest from different countries to share experience with the vitreoretinal surgery around the world. Today, we have a very special guest and a dear friend to the Egyptian Vitreoretinal Society and to me, myself especially, Dr. Khalid El-Sabti from Al-Kuwait. Dr. Khalid El-Sabti is a famous vitreoretinal surgeon devoted for his work, and he is building a very good career in vitreoretinal surgery in Kuwait. He's a dear guest and invited to most of the vitreoretinal meetings all around the world, and he have a lot of innovations in the field of vitreoretinal surgery. Dr. Khalid, welcome to us.
Hello, thank you, Sharif, for this introduction. Thank you for the invitation, and I'm very happy to be with you tonight.
Dr. Khalid, was it one of your dreams when you was a kid to be an eye doctor?
Not really. I always wanted to be a pilot for some reason.
Pilot.
Yes, enjoy showing that. I mean, so fascinated with the airplanes. And in the high school, maybe at the end of high school, I started to think about medicine as a career. And then I went to medical school in Kuwait, and then and ophthalmology came to me only when I was in my final year rotation. And, you know, I had a very interesting medical school career where I was studying in Kuwait, and then Iraqi invasion came at the very end of my training. I was in the 6th year, and we have a 7-year program. Then I had to go to Scotland, to Glasgow University, to complete my medical education. So during my training in Glasgow, one of the rotation was in the Tennant Institute of Ophthalmology in Glasgow. And here where I started to enjoy and seeing different specialty with high tech and very neat and very elegant. So I started to think about it. And it was between two choices, either cardiology or ophthalmology. And I think I made the right decision to go to ophthalmology.
Was it a special person in Scotland that made you make this decision, or just the training program?
I think the rotation at the Tennant Institute in Glasgow was one of my best rotations. And at that time, I think there was a lot of visitors from all over the world. I remember, I think one of them is from Singapore. He was doing his training at the Tennant Institute, and it turns to be one of my friends now, Dr. Donald Tan from Singapore. He's a very famous cornea surgeon. So he was trained in Glasgow, or he had spent some time, and I think one of them, he was teaching me how to use the slit lamp and how to examine the eye. And I think I got interested at that time when I was doing the rotation at the Tennant Institute.
Then out of the specialties in ophthalmology, why you did pick the vitreoretinal specialty?
It's a very tough question, Sharif. I think we like the challenges. I like the challenges, and I think you agree with me that retinal surgery is a quite challenging specialty, and in addition to that, it's one of the fastest growing or improving specialty among all, where the technology plays an important role in our career and our work. So I think this is what makes retina is fascinating, because you continue to learn, and you always improve your skills, and you always in touch with technology. And as technology improves, you also learn a lot and improve a lot. And it's a two-way, kind of communication between you as a surgeon and technology. This is one part of it. The second part is the teaching. I think teaching in retina is more interesting perhaps than other specialties. And that's why, and I like teaching. I think teaching is a good opportunity for us to learn from each other.
I think there is something in common between being a pilot or a vitreoretinal surgeon. Both are dependent on high tech, both are fast growing, and both of them should be ready to the unexpected, because as a vitreoretinal surgery, not a single case is like the other. and you should be ready for surprises, for manage complications. You make decisions right away and should be fast. And I think you are doing very fine as a veterinary surgeon, as pilot surgeon.
Well, Sharif, I'm actually a pilot as well.
Good.
I did my flight training at Miami, and I'm actually almost getting the license. So I'm almost 3/4 of getting the license. So perhaps when I go to the Retina World Congress next in 2 months, I'm going to finish off. So I still in my mind to be a pilot, and I agree with you. Both share a lot of things.
So what about the vitreoretinal surgery in Kuwait? I know that you are working in a very high-tech special hospital, and I remember I visited this hospital. I was impressed by the quality of the service you are doing. And tell me about the private sector in Kuwait and versus the governmental sector regarding the vitreoretinal surgery.
Sharif, you know that I worked in both. Actually, I was in the government hospital for a long time, during which I joined the university as one of the academic staff. And I personally, with the other doctors, we established our residency program in Kuwait. So I had a lot of experience in the government sector. But when I moved to the private sector, it is different. It's you have full control of everything. So in my hospital or in my private hospital, we have the freedom to do everything. Plus, what made the private sector grow in Kuwait is the recent introduction of the medical insurance among a big sector of the population in Kuwait, and that did give a boost to the improvement of the private sector in general, and ophthalmology in particular, where there was a competition, and whoever has a good reputation will take a big share of the market. So that actually it's a healthy kind of challenges where only the good ones will stay, and unfortunately the poor providers will fade away with time.
So it's an open market, and the chances for the good people to take over. And if the patient is free to go to private or governmental hospitals, or he can pick any professor or doctor upon his request, or if there is a waiting list for that.
In the government, yes, there is a waiting list, and sometimes you may not be able to choose a certain doctor. Sometimes it's difficult. But in the private sector, of course, you can choose any doctor you want, or any surgeon or any clinic you want. And actually, what we have seen, and which is really sometimes it's good and sometimes bad, a lot of patients takes multiple opinions from different doctors because they are insured, they don't pay for it, and they keep shopping around between many different doctors. So that is sometimes we see it in private sector, but the patient can choose the surgeon more freely in the private than the government sector.
I remember when visiting the Gulf nations, including the Kuwait, I've seen a lot of diabetics. So is it diabetes is the main challenge you are facing in your patient, or is it detachments, or the trauma, or is it ROPs? What is the main pathology that you are facing every day?
It is a mixture of many things, but as you mentioned, Sharif, I think diabetes is the leading cause of blindness in Kuwait, and it has been, and I think it will be for a long time, despite the fact that the patient education and screening program is being improved, but still diabetes. You know, I think diabetes in Kuwait is approached around 35% of the population. I think we are one of the highest in the world, and maybe the highest in the Gulf. And lifestyle, many things contribute to this high incidence of diabetes. And the effect of diabetes on the eye is something we see every day. We don't see cases like, I would say 10 years ago, where a lot of patients present to us in a very advanced stage. Now we are seeing relatively earlier stages, patients are getting more educated. And, you know, with the advancement of the treatment, we have options now, we have injections, and doing much less laser than before. I think that had improved the outcome of the treatment compared to many years ago, but still diabetes is the number one. Other cases we see a lot of detachments. I don't see a lot of trauma in private sector, but my colleagues in the government hospital see trauma and ROB as well.
Are you training patients from nearby countries, or you just Kuwaitis or an expats in your country?
We do get patients from eastern part of Saudi Arabia. We get I have getting a growing number of patients from Qatar, few patients from Oman, few patients from UAE, but mainly locally from Kuwait and from eastern part of Saudi Arabia. And this has been increasing in the past few years, except when we had the pandemic, where, you know, the travel was restricted and we had a big decline during the pandemic period. But now it is rebounding again, and we are getting more patients in the past couple of months.
Regarding obesity as a risk factor for diabetes, I've seen in Kuwait the percentage of obesity is somewhat high. And this goes to the next part of my question. What are your best food that you'd like to eat?
I think, you know, Sharif, if you don't know, they call Kuwait as the food capital of the Middle East, where you get any taste, any restaurant you want, whether Japanese, Lebanese, Korean, anything. And I think the competition in the food industry is so high. For me personally, I like Lebanese food. Lebanese food, I think it's a very fine food, and it's relatively also healthy in a way, a lot of salads, etc. So I think Lebanese food, and also I do like fish, seafood. Seafood is also my favorite.
Other hobbies apart from driving planes?
I like diving. I do.
So you go two directions.
Yeah, I do scuba diving. In fact, I like to. The best spot I had the opportunity to dive is Sharm el-Sheikh. It's a beautiful diving spot. It's really fascinating. So I like diving. I learned also diving just before the pandemic, and last month I had the chance to dive a few times. So I like diving, and I think you should try it. It's very good. Other than that, it's just no particular sport I like. I mean, sometimes if I had the chance to play tennis, but not anymore. I'm slowing down now. I don't have time. I wish I do have time to practice some sports.
I know that you are maybe the only doctor in the family, but do your children would like to go for medicine? You'd like them to go for medicine? Would you push them to go for medicine?
No, they are. My son is in the residency program in ophthalmology.
Yeah,
and my eldest daughter, she is a dentist. She wanted to do something not really like medicine, what we are doing. So she went to dentistry, which is, I think, for female doctors, it's a good specialty. So she's a dentist also. The youngest one, which is the last kid, is she decided not to do medicine at all.
So you have a good mix of ophthalmology, dentistry, and something else.
Engineering.
Very good, very good. It's a pleasure knowing you personally, Dr. Khalid, and maybe I will have a time now to slow down and go for a pause and then prepare for your interesting scientific contribution. Thank you.
Thank you, Sharif.
Now we are back after the pause, and now we are ready for the scientific part of this episode. Dr. Khalid Al-Sabti will speak to us about management of vein occlusion or surgical options in the management of vein occlusion. We know that vein occlusion is a common disease in our country, in our region, and usually it's treated medically. But the advent of surgical opportunities to open the gateway to relief of these symptoms will be very interesting. So we are very interested to listen from Dr. Khalid about his techniques in treating vein occlusion.
Thank you, Sharif. As you said, the surgical management of vein occlusion went through phases. In the probably 80s, there was a big hype of interest in vascular surgery, and then it disappeared. And lately, with the introduction of the anti-vascular growth factor, the result was good, and people are started to be away from surgery. However, I'm going to show you here is surgery. We should not forget surgery. Surgery in selected cases can give a good result. And I'm going to share with you two cases. Two videos will be narrated. So we'll talk about the retinal vein occlusion, any opportunity for surgery. And I'm going to talk in particular example. One of them is for central retinal vein occlusion, and the other case is for branch retinal vein occlusion. And I have no financial interest in this presentation. So as you mentioned, it's the central retinal vein occlusion is perhaps the second or third cause of blindness worldwide. And it has gone through many ways of treatment, including surgical treatment before, as people used to do either laser to create an anastomosis. The technique was described by one of the Australian doctors, and by laser to creating a arteriovenous choroidal venous anastomosis, and to the more invasive way of doing it. And I think both of us have seen RON, radial optic neurotomy, where people stick an MVR knife and try to cut the sheath or the circular band of fibrosis, trying to relieve the pressure on the vein, and that was also had a lot of complications, and people start to be away from it. Perhaps the most acceptable way is the intravascular injection of TBA, and some people had described improvement in vision in early presentation up to 50% see 3 lines or more. And I had opportunity to do a few cases of those. I'm going to share with you one of them. So how to do branch retinal vein occlusion, central retinal vein occlusion is to use a special cannula to go intravascularly and inject TBA, 3 microgram of TBA intravascularly, hoping that will dissolve the clot and reestablish the flow of the occluded vein. And as anybody would expect, it is a time issue where the earlier you interfere, the better chances for you. So this is one of the cases. This is one of my cases. Can you hear the video? 6 months. Yep. I want to share with you, in which I injected TBA using a microinjection kit connected to a 48 metallic cannula. We have to be very careful while introducing the cannula so it will not be damaged. And my second challenge is to find the right spot to perforate the vein and start injecting. And after 2 trials, I found the straight proximal dilated vein in which I was trying to cannulate, and was successful and started the injection of intravascular TBA. As you can see, the pulsations of the vein, followed by pulsations of the artery and blanching of the arteries and the vein, indicating enough circulation of the TBA within the vascular system. Once satisfied with my injection of 400 microgram, I pull out the cannula from the vein and increase the intraocular pressure to control the bleeding at the end. Of course, switching to air fluid exchange will help controlling the bleeding, and surprisingly, most of these cases, the bleeding is self-limited and it clears very quickly. So this is for central retinal vein. For branch retinal vein, is the pathology is different. It's a localized occlusion or compression on the vein by the overlying artery. And I think among the surgical management, I think this is the most successful because anatomically you go in and with a knife you relieve the fibrosis which constricts the underlying vein, and then sometimes if you do it early, you will reestablish the flow. And I have actually a few cases where this was successful. So this you can do it alone or you combine it with anti-VEGF treatment. So either you do sheathotomy alone or with anti-VEGF treatment and perhaps laser at some point. So I'm going to show you a case, very interesting case. This is a case with inferior branch vein occlusion involving the macular region. And as you can see here, this is the surgery. There are several ways to create sheathotomy. My preferred way is using spatulated curved 10-0 nylon needle connected to the thread to prevent the needle from hitting the retina. After creating sheathotomy, I use the needle to create sheathotomy proximal to the crossing area. And once sheathotomy is created, I switch to blunt spatula to extend my sheathotomy towards the crossing area and beyond to make sure that the enough relief of compression by cutting the sheath and relaxing the connection between the artery and the vein. Of course, with using new technology to use the high magnification, enhanced depth perception, and color filters, which can be helpful in highlighting the blood vessels and making sure that we are in the right spot between the artery and the vein. And we should continue dissecting the sheathotomy or doing sheathotomy beyond the crossing area until we are satisfied that we have enough is being done to reestablish the flow in the underlying vein. So this particular case is showed an excellent improvement just by looking at the fundus photography on a weekly examination. This is on the left side was the preoperative, and the second fundus is 1 week, and then 2 weeks, and then 3 weeks, which is indicating the reestablishment of the vein flow. So to conclude is that surgery may offer a better outcome in selected cases, and the most predictable factor in the success of surgery is the timing of surgery. The earlier the better, and the benefits of surgery may outweigh the intraoperative risks, and that was possible because with the advancement of our visualization and instrumentation, that it improved the outcome of the surgery compared to 20 or 30 years ago.
Thank you very much for this difficult surgery. I know that the duration, as you've said, is a crucial factor in the prognosis. So what is the best time frame between the incidence of the vascular occlusion and the intervention that gives you the best results? And when you say that it's too late?
If I have a good guess for CRVO, probably less than 6 months. So 6 months is the cutoff where maybe surgery may not work. The younger the patient, actually, it's the better also chance of the success of surgery. So if you get somebody who's like in his 30s or 40s, better than somebody in his 60s and 70s. For branch vein occlusion, it depends. I mean, if it is a macula involved, I do and interfere with surgery. And again, probably for branch vein occlusion, macular involvement is I probably interfere a little earlier, maybe 3 to 4 months. The other thing is what I do is that when I examine the patient, I compress the eye while I'm using the 90 diopter. Sometimes you see the pulsations, so you know that this vein is patent, but it's being compressed by an overlying artery. So this is give you an indication that surgery will work. But if there is no pulsation, and the chances probably it will not work with you. So you had to go and do the injections.
Good. The second thing that the human tremors, I imagine this is a very delicate surgery, and you are dealing with a very fine needle close to a very small vein. So cannulation of a very small vein by a very fine needle is something difficult with the human tremors. So what about the robotic surgery? Do you think that robotic surgery can have a role, especially in these types of surgery?
Yes, and I think I have seen the robot at the Academy in 2019 that was designed by Mark D. Smith.
Mark D. Smith is a good friend, and that's why I'm posing this question.
And I think that this is the biggest indication of robotic surgery is the microsurgical technique that cannot, as you mentioned, be handed over by a surgeon, or probably surgeon with a little bit of tremor. You know, you're cannulating 100 micron vein with a 48 gauge cannula. Imagine how difficult it is. As easy as it looks, it is really not easy. And even for me, you know, my success of cannulating the vein, I would say 50% or less in every case. So yeah, robot definitely. And I actually tried it at the Academy, where at the booth, the Mark D. Smith is. It's called Precise. The machine actually it's available commercially. Somebody can buy it. So that particular robot is designed for that purpose, or to inject in the subretinal space. And I think that will, if somebody can use it, I think the success of cannulation of vein would be quite high.
Also, that second challenge, the technology of the machines. I mean, the needle that perforates a vein should be very sharp. So if the needle made of glass, steel, Teflon, or what is the needle is made of?
It's a steel. It's a 48 gauge cannula. It's designed, I don't remember the company, but it's a Korean company. They do it straight or curved. And I love this cannula. But the problem is so delicate. A couple of times I damage it while I'm introducing the inside the. So sometimes I have to remove the cap of the plastic rubber of the cannula. So when you push it in, you don't want to
resistance.
Yeah.
It can bend easily.
Yes.
Yeah. And you're injecting with the viscous fluid injecting machine, I mean, and what is the pressure in the machine that you go for injection?
Yeah, I use the there is a micro injection kit by Med1.
Med1, I know.
Yes, and you use the viscous fluid injection kit. So you have the adapter and you connect it. And I start with a very low pressure, and I build up gradually. So I try it, I test it before, make sure the fluid comes not very strongly, but the flow is free, and then I cannulate and I start with a foot switch. So you minimize your movement. So and you focus on the cannulation, and you press your foot switch.
Do you think that TPA is essential, or just the mechanical flushing by fluid, whatever the type of fluid, can do the same?
I think both are important. I think there might, the chances that there is a clot is very high, especially with the stagnation of blood flow. So you might as well inject. I mean it's not from us, it's from our cardiology colleagues, where they inject the TBA and streptokinase and the coronaries, and they establish the flow. And with the thrombolysis, pharmacological thrombolysis, I think the same principle applies here. If it is a clot, which I think most likely it is a clot, then TBA is essential.
What about hemorrhage? Everybody will be dreadful of the hemorrhage because you are opening a vessel. So logically, you are expecting hemorrhage, but the videos you've showed, the amount of hemorrhage is not that much, and you said that it can be controlled by elevating the pressure, and it's not an issue.
Surprisingly, you don't get a lot of hemorrhage, and I don't know why. What is the reason? It's you're opening a very proximal vein. You want to be as proximal as possible to the central vein because the diameter you want. And surprisingly, despite that you have a very engorged vein, which I believe the pressure is quite high in that vein, it doesn't bleed. I think it, for some reason, it doesn't, like it constricts or something happens, it does bleed little and it stops. And actually, I've done perhaps 10 cases of CRVO. I don't recall one of the cases that had severe bleeding.
And the time frame for improvement, does it take a month or more for the patient to appreciate the visual gain?
If improvement, you can see in a month, with the fundus photo, you see that first the intraretinal hemorrhages disappear. It is not as dramatic as you would expect it to be. That's very important. People will think, I mean, you do it, you open the vein, even if you open the vein, you don't expect to see anything in a week or two. Maybe in a month, you look, you see, okay, I think the veins are less engorged, but there is less intraretinal hemorrhages. And then as time moves on, then things will improve. But you will continue to see the difference between the right and the left eye, even if you reestablish the vein. I don't know why, but I guess maybe the flow is not going to be as normal as before.
You do post-operative angiography to evaluate the flow or DOP, whatever. What do you test the flow by?
I don't, clinically, you see less hemorrhage and you see less edema with OCT. I mean, especially some of the cases, I don't inject anti-VEGF because I don't want to confuse myself. I would say, yeah, well, anti-VEGF did it or the surgery did it. So I usually postpone the anti-VEGF treatment at a month or more. So just to make sure surgery did its work, and then the residual edema, I can take care of it with the anti-VEGF injections.
Thank you, Dr. Khalid, very much for being a very nice guest and for showing us 2 elaborative videos showing the skills you have. And I thank you very much for being with us and hope to see you soon in Egypt in our meetings.
Inshallah. Thank you. Thank you for the invitation, Sharif, and good to see you again.